Okay, good morning. Our session today is about the heart and pericardium. This is a section in the thoracic cavity, and you can see the pleural cavity is on the side surrounding the lung, and in the midline, the region is called the mediastinum, part of the mediastinum, which is called the middle mediastinum. I'm going to talk about parts of mediastinum next time. One part of the mediastinum is called the middle mediastinum. It contains the heart. So you can see the location of the heart and the middle mediastinum, and you can see that the heart is central in its location here in the section and region-wise, and it's also the heart has a central functional importance in the cardiovascular system-wise. It's the double pump that pumps the blood through the entire cardiovascular system. Also in this section, note that the heart is located between two hard structures. So there's anteriorly, there's the sternum as a bone, and posteriorly, there's the vertebral column. That's why the heart can be compressed between these two bones, and this is what we usually use in cardiopulmonary resuscitation, compression of the heart. The heart can be compressed because it is sandwiched between two hard structures. This is very important to consider. There is a physiologist's heart or a, let's say, lover's heart, but this is by no means related to the anatomical heart until you do some modifications to it. So in a physiologist's heart, from the functional point of view, it will be enough to say that there are two atria on top of two ventricles, okay? And the heart looks like a lover's heart. But from the anatomical point of view, in order to convert this heart to the actual anatomical relations of the chambers of the heart, you need, first of all, to put the heart, the physiologist's heart, on its right side, and then rotate it in a clockwise direction. And in this case, you will find that the right side of the heart will occupy most of the anterior surface of the heart, and the left side of the heart will be posterior. Look at the actual anatomical heart here. You can see that although on the anterior surface you can see all the chambers, the four chambers of the heart, but the most of the anterior surface is occupied by the right side, the right atrium and the right ventricle. There is a groove here between the atria and ventricles, which is called the atrioventricular groove or the coronary groove or coronary sulcus, and separates right atrium from the right ventricle. In fact, the right ventricle is the biggest chamber that appears in the anterior surface of the heart. And then you will find that there's a very narrow strip of the left ventricle also on the anterior surface. Note that there is another groove, which is called interventricular groove, as the name indicates, between right ventricle and left ventricle. So it's called anterior interventricular groove because it is on the anterior surface. And there's a very small area here, an auricle of the left atrium that is shown. But the striking feature on the anterior surface of the anatomical heart is the right side, and the biggest chamber that is represented here is the right ventricle. The other surface of the heart is called the diaphragmatic surface, and it is where the heart rests on the diaphragm, particularly on the central tendon of the diaphragm. So this is called the inferior surface or the diaphragmatic surface. And you will notice that on the diaphragmatic surface, the most important chamber is the left ventricle. The biggest chamber is the left ventricle. There is a small amount of right ventricle, and the right atrium immediately receives the inferior vena cava. The left atrium does not reach the inferior surface. It's higher up. I'm going to talk about the left atrium in a moment. So there is, again, I repeat, there is anterior surface of the heart. There is inferior surface of the heart or diaphragmatic surface. The heart lies on its inferior surface, but this is not the base of the heart. The base of the heart is another surface. It is the posterior surface, because the heart is represented as a cone, and the cone has an apex and it has a base. So the base is opposite to the apex of the heart. Here is the apex of the heart. It is formed by the left ventricle, and the base of the heart faces the apex. It is the posterior surface of the heart or the left atrium. Probably here it will be difficult to understand, but I'm sure that when you're going to go to the practical, you will see the actual heart and its location, and then you are going to, today what you are going to do is to open the pericardium, and by yourself you detach the heart. You will notice that there is something behind the heart, posterior surface, to the left atrium, which receives the 4 pulmonary veins. And you are going to cut these veins, the 4 pulmonary veins, and before you can detach the heart. So just to make sure that the base of the heart at this moment, the base of the heart is not the diaphragmatic surface. The diaphragmatic surface is the inferior surface. The heart lies on the inferior surface, rests on the inferior surface, but this is not the base of the heart. And the concept of the base is the concept that there is a cone, and so it has an apex and a base. So the base, and the heart does not lie on its base. The base is the posterior surface of the heart, and it is formed by the left atrium, as you can see here. This is how you see the heart, the cardiovascular silhouette. Here you can see that the right border of the heart is formed by the right atrium. Inferiorly, there is the right ventricle, and the apex of the heart, always the apex is the left ventricle. The apex is the left ventricle. That small narrow strip of the left ventricle that appears on the anterior surface of the heart. Then the left border of the heart is mainly the left ventricle, and there is a small area here that represents the auricle of the left atrium. So a small area here. When there is enlargement of the left atrium, it will cause a bump at this location. Okay? This is to show you the surface anatomy of the heart. If you look here at the inset, you will find that the heart, 1/3 of the heart is located to the right of the midline, and 2/3 of the heart is located to the left of the midline. So it's not the entire heart that is located to the left. There's part of the heart which is located to the right, and this is the approximate surface anatomical landmarks. Approximately the superior border is level almost with the sternal angle, and then the right border passes along or parallel to the right border of the sternum, and then we have the inferior surface at the level of the xiphisternal joint, and then the left border. So this is the inferior border. We have the inferior border on the level of the xiphisternal joint, approximately, and then the left border meets the left end of the superior border. Again, the most important thing here to keep in mind of all these relations is the location of the apex of the heart. This area where you can put your stethoscope or you can feel the pulsations. It can be felt. And this location is the left 5th intercostal space, just medial to the midclavicular line. You will be able to identify the midclavicular line when you feel the 2 ends of the clavicle, and in your mind's eye, just to draw a vertical line, that would be midclavicular. And then the 5th intercostal space can be approached by counting the ribs. How do we count the ribs? We feel the sternal angle, and then we start counting the ribs and the intercostal spaces until we reach the 5th intercostal, left 5th intercostal space, just medial to the midclavicular line. Sometimes people say that we can use the nipple. It is infromedial to the nipple, but the nipple is not a reliable surface anatomical landmark because the position of the nipple and soft tissues varies from person to person. The important thing in surface anatomy is that it's better to use bony landmarks. And the bony landmarks here are the clavicle, midclavicular line, and the ribs, intercostal spaces, and the sternal angle. The wall of the heart consists of 3 layers. You are going to study this in the histology, I hope. It's the same as a distended blood vessel. There are 3 tunics, tunica interna, tunica media, and tunica externa. Again, here we have, in the heart, we have an endocardium. It's lined with simple squamous epithelium and some subendothelial connective tissue. And then the main thickness of the heart is myocardium, which consists of cardiac muscle fibers, myocardium. And the myocardium varies in thickness depending on the function of the chamber, the pressure that is produced by the chamber of the heart. So it is thickest in the left ventricle because the left ventricle pumps the blood to the systemic circulation against 120 millimeter blood pressure. So it is very thick in the left ventricle, as you can see it here. This is the left ventricle open. And then the outermost layer is called the epicardium, which is actually part of the visceral pericardium. I'm going to talk about the pericardium in a moment. This is a section in the heart showing the heart as a double pump. The right side of the heart has a right atrium. On each side, each pump has an atrium and ventricle, and in between them there is an opening guarded by a valve. The opening is obviously called atrioventricular opening, so it's either right or left, and guarded by atrioventricular valve, either right or left. The right one has 3 cusps, and so it's called, the other name is called tricuspid. The left one has 2 cusps. The other name is bicuspid, or it's called the mitral valve. You can see here that the right atrium receives deoxygenated blood, blue, from the superior vena cava, inferior vena cava, pushes the blood into the right atrioventricular orifice to the right ventricle. When the right ventricle contracts, it pushes the blood to the pulmonary trunk and pulmonary arteries. The blood goes to the lung, become oxygenated. Here again, there is a valve, which is called the pulmonary valve, which prevents blood returning back into the ventricle during ventricular relaxation or diastole. And then the blood goes to the pulmonary arteries, oxygenated, returns by pulmonary veins. 4 pulmonary veins enter into the left side, left atrium. You can see it's red, it's oxygenated. And then the left atrium pushes the blood through the left atrioventricular opening, which is guarded by valve. This valve prevents the blood from regurgitating, passing back into the left atrium when the ventricle contracts, ventricular systole. So systole and diastole. So when the ventricle contracts, this valve is going to open, and the left ventricle is going to push the blood to the aorta to be distributed to the body. And here again, there is another valve, which is called aortic valve. So all in all, we have 4 of these valves. We have 2 atrioventricular valves, right and left, and we have 2 other valves, one of them at the beginning of the pulmonary trunk, so it's called the pulmonary valve, and the other one is at the beginning of the aorta, and so it's called the aortic valve. And they make sure that there is a unidirectional flow of blood, allowing blood to pass in one direction, preventing blood from returning back. Although they have different structures, each couple of them has different structures and different mechanism of closure, as we will see later on. This is what you are going to do in the practical. After you open cut the pericardium and then detach the heart from the great vessels that connect to it, you are going to cut the superior vena cava, inferior vena cava, the pulmonary veins, the aorta and pulmonary trunk, take the heart out, and then make an incision on the anterior surface or the anterior wall of the right atrium and open the right atrium. So when you open the anterior wall, you are going to face the posterior wall. You can see that most of it is smooth. The posterior wall is, in fact, the wall between the 2 atria. Remember that the left side of the heart is located posteriorly. So behind this wall lies the left atrium because it is posterior. Okay? So this is what we call the interatrial septum. And you can see here that there is an oval area, an oval depression, which is called fossa ovalis. It's like a thumbprint size depression. This was an opening in the embryo. It allows blood to pass from the right atrium immediately to the left atrium, because in the embryo, the right atrium receives oxygenated blood from the placenta. So it receives oxygenated blood through the inferior vena cava. What is the use of pumping the blood to the lung at the time that the lung is not inflated? So that's why there's a bypass here, a shortcut that pushes the blood from the right atrium to the left atrium, so that the blood will be pumped by the ventricle to the systemic circulation, bypassing the lung. There's no oxygenation taking place in the embryonic lung. So that's why there is a foramen here, which is called foramen ovale. And this will immediately be closed after delivery. If it is not closed, then this results in what we call interatrial septal defect and might need surgical interference, as we will see that in one of the videos in the lab. Okay? So openings of vena cava, and then there's here, you can see that there is a ridge of cardiac muscle fibers, and there are almost horizontally lying ridges of cardiac muscle fibers. They give the appearance of rough surface, but actually the surface is not rough. It is smooth because it is lined with endothelium. I mean, microscopically speaking, it is smooth because otherwise it will result in clotting of the blood. But grossly speaking, it is a rough surface. It's not smooth like in the remaining part of the atrium. And so this ridge is called the crista terminalis, and these are called the pectinate muscles or musculi pectinati, and also they occupy the small auricle here of the atrium. Both atria, they have a small auricle arising from them, and the auricle is usually rough. And then you can see the right atrioventricular orifice here, and there is a small opening, which is the opening of the coronary sinus. I will talk about the coronary sinus in a moment. The coronary sinus is the big venous channel. It admits the tip of the little finger, and so it's a big venous channel that drains the blood that supplies the heart. So the heart itself, as I mentioned, is a very active pump. It requires a lot of oxygen and a good blood supply. And the blood that is present inside the chambers of the heart will not be enough to penetrate through all these layers of the heart to supply them. So it requires a circulation, its own circulation, which is called the coronary circulation, coronary arteries, and drained by veins that ultimately drain into a single channel, which is called coronary sinus, that, like any other venous blood, should accumulate or should collect in the right atrium, so it opens into the right atrium, but it drains the blood from the heart itself. Then we have the right ventricle. Again, we are going to open the right ventricle in the practical, and you will find that it has a rough surface, which is again, it is formed by it's formed by cardiac muscle fibers. It's a little bit thicker. It's a little bit thicker than the right atrium. The wall is a little, but it is thinner than the left ventricle. You can see the opening here of the tricuspid valve, 3 cusps, and there is another opening here of the pulmonary valve, which is it is guarded again by 3 cusps, but these cusps, they look like cups and they are like half moon. So that's why they are called, the valve is called semilunar valve, half moon. The thick parts, these are like logs of cardiac muscle fibers, so they are called trabeculae carni. So carni from carnivore, meat. So it's like logs of meat which are present here. We don't call them musculi pectinati, but we call them trabeculae carni. Some of these cardiac muscle fibers project as finger-like projections with the free ends, and they are called papillary muscles. And from the papillary muscles, there are strings of fibrous tissue called chordae tendineae, which attach to the cusps of the valve. So before the ventricle contracts, or just milliseconds, these papillary muscles, because they are formed of cardiac muscle fibers, they are going to contract. they pull on the chordae tendineae, the strings of the heart. So they pull on them, and these chordae tendineae are going to pull on the cusps of the tricuspid valve and prevent their eversion. That's to say, opening the other way around. And so they pull on them like strings pulling on a parachute. Okay? And this, so the valve, when the valve closes, it will not evert back. And this will prevent regurgitation of blood to the atria. So the blood has only one way to pass, that is to pass through the pulmonary opening, which is guarded by the valve. So it's going to push these cups in front of it, these semilunar cusps in front of it, and will go to the pulmonary trunk. One of the trabeculae carni, one of them only, and only in the right ventricle, as you can see it here, is attached by its two ends. Otherwise, it's free. So one end is attached to the interventricular septum, the other end is attached to the anterior wall, and this is called the septomarginal trabecula, or the moderator band. The importance of knowing about it is that it transmits what we call the right bundle branch of the conducting system of the heart. I'm going to talk about the conducting system in a moment. And this band, which is only present in the right ventricle, a feature of the right ventricle, transmits the right bundle branch, or it's called the moderator band, because it connects between the interventricular septum and the anterior wall. So it's like a rope connecting between these two and prevents over distension of the ventricle. So it moderates the amount of distension of ventricle. That's why it has the other name, because it's connected in between these two walls. The left atrium, most of it is smooth, and remember, the left atrium is the base of the heart. It receives the four pulmonary veins, and it has a small auricle, which is rough, and it opens by the left atrioventricular opening, which is guarded by the mitral valve. It has two cusps, so it looks like a bishop's mitre. That's why it's called the mitral valve, or you can say it's the bicuspid valve as opposed to the tricuspid valve. And it has the same structure and works exactly the same like the tricuspid valve. So there are papillary muscles, there are chordae tendineae, and they control the movement and prevent eversion of the valve during ventricular systole. The striking point here is the thickness of the wall of the left ventricle. Of course, there is no septomarginal band. Look at the thickness of the left ventricle. And in section, the interventricular septum, this is a transverse section, the interventricular septum has the thickness of the left ventricle. It is part of the left ventricle. So the section of left ventricle looks like a circle, like a donut, and the section in the right ventricle is crescentic. It's like a croissant. So these valves, we have four valves, two pulmonary, two atrioventricular. They are all, anatomically speaking, they are all located behind the sternum. And when they close and they are tense, they're going to produce heart sounds. So we have first and second heart sound, lub, dub, lub, dub, first and second heart sound. But when these valves are closed and they become tense, they will produce this sound. It's like a piece of cloth. When you tense it, it will produce the sound. Okay? It's like the heart sounds. So the first heart sound is produced by the closure of the atrioventricular valves, and the second heart sound is produced by the closure of the pulmonary and mitral valves. Now, because they are located in one location, so it's very difficult to distinguish between which sound is produced by which valve. So if the valve is abnormal, we cannot exactly say which valve if we just put the stethoscope in the anatomical location. So what they do is that there are certain auscultatory areas which are separated from each other, And the physics behind it is that the blood tends to carry the sound of the closure of the valve to the direction of blood flow, in the direction of blood flow. And these areas are located most superficial to the chamber or the vessel where the sound is carried to. So that's why, for example, the mitral valve, the blood direction will be in this direction. So the mitral valve is best auscultated at the apex of the heart, left fifth intercostal space in the mid-clavicular line. The tricuspid valve is best heard or auscultated behind the left side of the lower end of the sternum. The aortic is in the second right intercostal space, just to the side of the sternum. The pulmonary is in the second left intercostal space, okay, just to the side of the sternum. And now you can easily identify or localize these locations when you by counting the ribs, by feeling the sternal angle and counting the ribs. So these are the auscultatory areas. They are widely separated from each other. You have one here, one there, one here, one there. So they are not collected in one area, and so you can easily distinguish the sounds, and there is an abnormal sound produced by these valves. I have just mentioned that the semilunar valves, these are a view from the superior surface of the heart. You can see here, this is during ventricular systole, and the semilunar valves are open. Atrioventricular valves are closed. Two, bicuspid and tricuspid, they are closed. And this is when, during ventricular diastole, the blood passes through the atrioventricular valves. They are open, while the blood cannot return back. Why it cannot return back? The reason is that these valves, whether the aortic or the pulmonary valve, if you look at them from in profile, you will find that they are like a cup, something like that. So during ventricular diastole, so we have a cup here again, and this is the vessel, okay? So during diastole, blood tries to return back to the ventricle. Let's say here, it is the left ventricle, okay? While the blood returning back, it will push, in front of it, it will push these cusps, and so the cusps will close. In other words, the closure of these valves, whether pulmonary or the aortic valve, is a passive phenomenon. You don't need something to pull on the valve, like in the papillary muscles, pulling on the strings in order to close the atrioventricular valve. So the closure of the atrioventricular valve is an active phenomenon, while closure of the semilunar valves is a passive phenomenon. This is to show you that sometimes the valves are narrow, so it's called stenosis. Sometimes they do not close completely, and this is called incompetence of the valve. Both stenosis and incompetence will put extra work on the heart. For example, let's say here, a patient with a patient with aortic stenosis. So if this valve, the aortic valve, is narrow, then there's an overload on the right ventricle. It has to contract harder than usual. With time, this results in enlargement of the left ventricle. Like when you exercise your muscles will get bigger. So this is what we call hypertrophy. Again, here there will be enlargement of the left ventricle, hypertrophy of the left ventricle. And as you can see here, if you look at the X-ray of the heart, look at the left ventricle. It's much bigger. The heart is much wider than the normal heart. If you go back to the normal chest X-ray and look at the heart, of course, you are not required to identify these things. I'm just showing them to you as an example of what you are studying. Look at the size of the normal heart. If the left ventricle, which constitutes the left border of the heart, is enlarged, then the heart will come to this until this end, as you can see it here in the chest X-ray of a patient with aortic stenosis. And when these valves are pathological, then they will be a very good site to be infected by bacteria and result in subacute bacterial endocarditis. That's why those patients should be treated with prophylactic antibiotics to prevent the infection if you are going to work on their teeth, or if you are going to do any oral procedure if their valves are defective, because the bloodborne infections can easily affect and damage or produce more damage on these valves. Apart from the myocardium, there is fibrous tissue in the heart, and this looks like a skeleton of the heart. So the skeleton, there's no bone in the heart, but there's fibrous tissue that works like a skeleton. So this fibrous tissue, either in the form of rings that surround the valves and prevent their over-distension. So we have 4 rings, and in between them, there are areas, triangular areas, that are also filled by fibrous tissue, fibrous trigones. And there is a very small part of the interventricular septum, which is membranous. Here, I can show it to you here in this diagram probably. It's a very small, narrow area of the interventricular septum that is membranous. All in all, the function of this skeleton of the heart is that to prevent over-distension of the valves, that's one thing, provides attachment for the cardiac muscle fibers so that they attach and contract, like for example, skeletal muscles are attached to the bones and cartilage, and so they can contract. Here, it provides a basis for the cardiac muscle fibers to contract. And the most important thing that you should keep in mind, that these act as insulators. So electrical activity is in the atria is insulated from electrical activity in the ventricles, unless the electrical activity passes through the conducting system of the heart. Cardiac muscle fibers, as you will study in the histology, they are connected with each other by junctions. The cells are connected by gap junctions, and these gap junctions allow the electrical signal to pass, or allow the electrolytes to pass from one cardiac muscle to another. So they are conductive, but the fibrous tissue is non-conductive. It's insulator. This is the conducting system. There is a node of modified cardiac muscle fibers. It's called the pacemaker of the heart. You cannot see it by your naked eye. So you just need to know the location. It is located in the right atrium at the end of the upper end of the crista terminalis, close to the opening of the superior vena cava. This is the pacemaker of the heart, and it produces and initiates impulses at 70 beats per minute. These beats are going to be transmitted. I'm sure that you probably will study that in the physiology, in the atria, until it reaches the point where there is another node, at AV node, is located in the interatrial septum, very close to the opening of the coronary sinus and the tricuspid valve. And then from that, the modified cardiac tissue passes into a bundle of His, which passes through the membranous part of the interventricular septum, and then it straddles the interventricular septum. It divides into right and left bundle branches. Right bundle branch passes into the moderator band to reach the anterior wall, and then the left bundle branch goes to the apex of the heart, and then we have what we call Purkinje fibers that you can only see by, of course, all of it. You can only see all of the system through the microscope, because they are modified cardiac muscle fibers. Again, I repeat, you will not be able to see the conducting system of the heart, but this is where it is located. And there is a plexus of nerves close to the heart, which is called the cardiac plexus. And this plexus is formed by the autonomic nervous system, sympathetic and parasympathetic nerve fibers. These sympathetic and parasympathetic nerve fibers, they control the SA node. So the SA node by itself, it produces impulses at 70 beats per minute. If there is sympathetic overactivity, this will increase the heart rate. If there is parasympathetic overactivity, this will reduce the heart rate. So the stimulation of the sympathetic nerve fibers, they are derived from the sympathetic trunk. I'm going to talk about the sympathetic trunk next time when I deal with the mediastinum. The parasympathetic innervation to this plexus comes from the vagus nerve. If you go back to the first lecture on the introduction, you will notice that the parasympathetic nervous system has a cranial outflow and accompanies 4 cranial nerves. One of them is the vagus, the 10th cranial nerve. And this parasympathetic outflow that accompanies the vagus is not distributed to the head, but it goes down through the neck, into the thorax, and into the abdomen. When the vagus nerve is present in the thorax, or even when it is present in the neck, it will provide fibers to the cardiac plexus. And these fibers are going to slow the heart rate and reduce the force of contraction. While the sympathetic fibers, they increase the heart rate, they increase the force of contraction, and they dilate the coronary arteries, because when the heart needs to pump a lot of blood, then it requires more oxygen, more circulation. So that's why the coronary arteries, the arteries that supply the heart, are going to dilate in order to increase the circulation. The heart is surrounded by a pericardium, which has the same story of the pleura. It's a serous membrane. The heart pushes itself into the pericardium. The heart is enclosed by the pericardium. The heart is not inside the pericardium. And the pericardium has a visceral layer and a parietal layer. The visceral layer is attached to the heart, and it is actually the epicardium, the outermost layer of the heart. The parietal layer of the pericardium is away, and in between them is the pericardial cavity, which contains a small amount of serous fluid that reduces friction, because the heart is always beating, so it reduces friction of the beating. The lung is inflating, deflating, the heart is always beating, so the pericardial fluid reduces friction. Added to this story of visceral and parietal serous pericardium, there is an extra layer in the pericardium, which is not present in the pleura, which is not present in the peritoneum. And this is the fibrous pericardium. So when you opened the chest last time, you noticed that the heart is surrounded by a very strong bag of fibrous pericardium, which you are going to cut today. So there is an additional fibrous pericardium in addition to the serous pericardium. The serous pericardium is divided into parietal and visceral layer, same as the pleura, but the fibrous pericardium is a single layer. It's located outside the heart, and it fuses with the parietal layer. So there is no space between the parietal pericardium and the fibrous. If you look at it like this is the fibrous pericardium, the thick layer. It is fused with the parietal layer. I'm going to show that to you better in the practical. The coronary arteries are the arteries that supply the heart, and they are called coronaries because they surround the heart like a crown. So that's why they are called coronaries. They are branches from the ascending aorta. Behind these cusps of the semilunar valves, there is a depression, which is called a sinus. And 2 of these 3 sinuses in the aorta, they have openings. You are going to identify them, called coronary openings. And this is the beginning of the coronary arteries. So the coronary arteries, right and left coronary arteries, are the first branches of the ascending aorta. You can see here the right coronary artery passes into the right coronary groove until it reaches the inferior margin of the heart, provides a branch which is called marginal artery. I'm going to show that to you in the practical. And then it passes on the inferior surface of the heart, here on the inferior surface of the heart, and gives what we call the posterior interventricular artery, and then anastomoses with the termination of the left coronary artery. Anastomosis, remember, arteries anastomose, mouth to mouth, so that to provide equilateral circulation, an alternative circulation if one artery is closed or is narrowed. The left coronary artery, it supplies an anterior interventricular artery, which anastomoses with the posterior. This is the artery that's most likely affected by narrowing and atherosclerosis, most of the cases. And then it provides another branch which is called the circumflex. As its name indicates, circumflex passes around the heart. and anastomosis with the termination of the right coronary artery. You can see here that these coronary arteries not only supply the heart, but also supply the conducting system of the heart. So you have a branch usually from the right that supply the SA node, and another one that supply the AV node, the conducting system of the heart. So whenever there's a problem with the coronary arteries, it's not only the myocardium that will be affected, but the conducting system, and this will result in dysrhythmias or arrhythmias of the heart. The heart will not beat regularly because of the injury that takes place to the conducting system of the heart. Veins accompany the arteries, but unfortunately they have different names that you need to memorize as well. So we have a great cardiac vein that accompanies the anterior interventricular artery, and this continues as the coronary sinus, which receives a middle cardiac vein and a small cardiac vein, and the coronary sinus opens into the right atrium, as I mentioned. It is the main venous channel that brings the blood back to the heart. When these vessels become narrow, they will not be able to supply the heart with blood, and this will result in what we call ischemic heart disease, either angina pectoris, which is a transient reduction in the blood supply of the heart, or myocardial infarction, where infarction means there is ischemia that results in death of myocardium. And the myocardium, when it dies, it cannot replace itself. It will replace itself by fibrous tissue, non-contractile, abnormal tissue. So that's why when they are narrow, even when there is an anastomosis, these anastomoses might not be enough to compensate. At one point, they will not be enough to compensate. So that's why these arteries are replaced. Either they replace them with a vein, like the saphenous vein. I will talk about this when we deal with the lower limb. Or sometimes they replace them with an artery, ulnar or radial arteries, or sometimes they just move the internal mammary artery. You have seen the internal mammary artery last time, and you have seen that how close it is to the heart. So they just, because it supplies the wall of the body and it has so many anastomosis, so they can take one of these internal mammary arteries and connect it to the nearby coronary artery distal to the site of obstruction to maintain the circulation. Or they can do coronary angioplasty. They pass a catheter. Usually the catheter is passed through the femoral artery. We are going to study that location of the femoral artery when we deal with the lower limb. Passes through the external iliac, common iliac, abdominal aorta, then thoracic aorta, arch of the aorta, until it reaches the ascending aorta. And so the catheter will be passed into the ostium of the coronary artery, and a balloon will be inflated here to enlarge, or sometimes they leave a stent inside to keep it open. Okay, this is called coronary angioplasty. I've just mentioned about ischemic heart diseases, either angina or myocardial infarction, and the pain here that results usually is felt on the left side of the chest, but it also is felt on the medial side of the arm. The reason for that, this is called cardiac referred pain. So pain arising from the heart is not only felt on the left side of the chest, but also it is felt on the medial side of the left arm. This is very characteristic for the ischemic pain arising from the heart. The reason for that is that the heart is not like a skin, is not somatic. So the nerves supplying the heart are not somatic nerves. They are autonomic nerves. They are sympathetic nerve fibers. So the impulse will be carried by these sympathetic nerve fibers, and these sympathetic nerve fibers, they connect with spinal cord segments T1 to T4. These spinal cord segments also receive nerve fibers from the skin, from T1 and T4. The skin, if you remember the dermatomes, the dermatome map, if you remember the dermatome map from the first lecture, you will notice that on the thoracic wall, there is T3 and T4, T2, T3, T4, and there's C4 here on the dermatome of C4 on the shoulder. The remaining dermatomes, T1 and T2, they are in the upper limb, because the upper limb grows, embryologically speaking, from the trunk. So that's why the dermatome of T1 and T2 are located on the medial side of the arm. So what happens here is that impulses reach the brain that there is something wrong between T1 and T4, and the brain cannot discriminate whether the pain is arising from the skin or is arising from the heart, because here it is the same spinal cord segments that receive pain impulses arising from the somatic areas, from the skin. They are the same spinal cord segments that receive pain impulses arising from the heart. So the patient will feel as if the pain is arising from the skin. This is called referred visceral pain. You will have so many examples in the body of visceral referred pains, and I'm going to describe many of them during this course. Okay, so this is called cardiac referred pain. It is the patient that will feel as if the pain, it's not arising from the skin, but it is felt as if it is arising from the skin. You have a question?
Yeah, I don't know if I'm really clear on what a dermatome is.
Oh, so a dermatome is a skin area. Derma, from dermis, is a skin area that is supplied by a single spinal nerve. Somatic sensation, pain, touch, temperature. Okay, the sensations from the heart. If you like, just imagine that if you can hold the heart of a living person, the heart or the viscera of the body, they do not feel the somatic sensation of pain, touch, and temperature, but they feel chemical sensation like ischemia of the heart. Okay, so this is visceral sensation. Now, remember that this was the trunk here, upper limb and then lower limb, and remember these dermatomes, the areas on the trunk, the map. Okay, so these are the dermatomes, area of skin supplied by somatic nerves. These somatic nerves are going to connect to the same socket that receives visceral nerves from the heart. So the brain will interpret these impulses as if they are coming from the skin. And that's why the patient will feel the sensation as if it is coming from the skin. Okay?